Okay, this is chapter 12. It's going to be part of the internet exam that you will take towards the end of the week. And it basically covers sleep-wake disorders. However, I'm just touching on the sleep-wake disorders that you all had not talked about in 101 under the sleep and rest section of Gordon's functional health patterns. So this is going to be very brief. It's just going to cover 2 or 3, but I do want you to go back and review in your book about insomnia, narcolepsy, those that you've already covered, just to familiarize yourself with those. I will be asking some questions concerning those disorders, but you've already had lecture on them, so I'm not going to repeat those. 21% of Americans believe that they have some sort of sleep disorder. Determination of the sleep disorder requires significant impairment of functioning. Remember, I talked about with any of these disorders, to diagnose one, it has to have that significant impairment of functioning. Basically focusing on those issues with safety, concentrating, and actually some cardiac symptoms can be associated with lack of sleep. The first one that I want to talk about that I don't think you've heard about is called circadian rhythm disorders. Now in your book lists quite a few circadian rhythm disorders. They are found on, let's see, let me get over here, page 226. In table 12.2, it talks about circadian rhythm disorders, and it talks about the ones that the American Academy of Sleep Medicine recognizes, as well as the disorders recognized by the American Psychiatric Association. And those are the ones that we're going to focus on, of course, the ones recognized by the American Psychiatric Association. And the big one that I want you to be familiar with is shift worker disorder, and that's basically what it is. 20% of Americans normally at some point in time are working on a night shift, and people who work night shift normally get about 2 hours less sleep per night than the population at large. So if most people with a population at large gets around 7 or 8 hours of sleep, people who work night shift normally get around 5 to 6 hours of sleep. So they're about 2 hours less. It's confirmed by polysomnography and multiple sleep latency tests. Those are the 2 tests that we use to diagnose sleep disorders. Issues secondary to shift work basically are social stressors as well as biological influences. And actually nurses are a prime candidate of shift worker disorders. It's prevalent in about 10% of the shift workers that work the night shift, so about half of those are seen there. So you just need to really focus on that. Like I said, it's talked on page 225 in your book. You need to review the DSM-5 criteria for insomnia disorders. That is also on page 226, and refamiliarize yourself with insomnia. It's on page 225, mild insomnia, moderate insomnia, and severe insomnia. Just refresh and renew your content on that. Also want you to refresh and renew your content on obstructive sleep apnea. I'm the one who lectured on that. No, I am not the one that lectured on that to you all. You will receive the lecture for that in Nursing 220. So I'm not going to cover it very in depth here, but you just need to understand what obstructive sleep apnea is, and there is a little paragraph on page 227 that actually describes that, labeled obstructive sleep apnea. And that's basically when somebody has snoring, recurrent absence of breath for more than 5 or more times an hour, accompanied by that nocturnal breathing pattern, such as the snoring. And they also have daytime sleepiness and fatigue. Due to the obstructive sleep apnea. The next thing I want you to focus on is restless leg syndrome. Restless leg syndrome is a neurological disorder. It is basically characterized by unpleasant sensations in the legs, and those unpleasant sensations require the person to constantly be moving their legs. It's basically what they described as creeping, and that's basically the need to feel that your legs are always moving. It usually increases as the day goes along. And it causes a person not to have good sleep at night. The sensation usually increases, like I said, from goes on and it worsens in the evening. To merit diagnosis, it must be at least 3 times per week for at least 3 months and cause that significant distress in function. There's also such thing as periodic limb movement. It's characterized just like restless leg syndrome, except this involves all movement. It involves the upper torso as well as the lower torso. Okay, some issues about wakefulness that I want you to remember. Again, narcolepsy you've covered. You've covered that in Nursing 101 with your sleep rest cycle. So make sure you go back and read basically what narcolepsy is. Most common sign of wakefulness disorders is that excessive sleepiness in the absence of a sleep disorder. So you don't have a sleep disorder that's keeping you awake at night so you don't sleep. Disorders of wakefulness basically means that you get the allotted numbers of hours at night for sleep. However, you still have that excessive daytime sleepiness. Can result in life-threatening motor vehicle and work-related accidents, and it affects patients and community safety, because if you have someone driving around with, say, narcolepsy and they fall asleep at the wheel, that is most definitely a danger situation. The one I don't think you were taught about was hypersomnolence disorder. This is excessive daytime sleepiness despite main sleep period of at least 7 hours. So these are somebody who gets sleep for at least 7 hours a night but has that excessive daytime sleepiness. The etiology is thought to be a neurochemical imbalance, and approximately 10% of patients reporting excessive daytime sleepiness will be diagnosed with hypersomnolence disorder. The age of onset varies, and it's basically neutral general. So there's no man or woman things that gets this any worse than others. What you do want to know with this is a diagnosis of exclusion. So you want to rule out everything else before we diagnose with hypersomnolence. It's confirmed by a normal sleep study, the absence of conditions that should be present with sleepiness and as symptoms. So, everything is normal, but they're still having that excessive daytime sleepiness. Associated symptoms can be lack of motivation, energy, decreased attention, cognitive performance, depressive symptoms. It's normally treated with stimulant medication, and it can also have present with sleep inertia, which basically is sleep drunkenness, in which the patient appears to be awake but displays the poor motor dexterity and inappropriate behaviors and memory as someone who was on some sort of substance. Now here's a table, and I have them all listed. Like I said, you have had these lectured, so you need to make sure that you read through these and understand how this manifests itself. For example, insomnia, in the biological side, you have decreased immune functions and fatigue. Physiological, you're looking at depression, anxiety, irritability. Sociocultural, insomnia can cause some social isolation, and then also in the spiritual realm. So there is that, and that chart is also in your book if you want to look at it in your book. So what do we do with people with sleep disorders? Well, we do collaborative care, which basically means more than one type of therapy. Normally, if it's a sleep disorder of sleeping, then you sort of have medication as well as some therapy. elicit from the patient when symptoms and impairments of functions are most troublesome, and discuss the patient's sleep with a partner also may be helpful. If you're doing that, you're getting the full view of the patient, because the patient might not know exactly what's going on, but I can guarantee you the person sleeping in the bed beside of them does. So we want to involve everybody in that. When we're looking at the psychopharmacological aspect of it, most over-the-counter medicines used for sleep have diphenhydramine in them, or basically Benadryl, and also can have some little low dose of alcohol in some of them. However, we should not use the diphenhydramine or alcohol on a long-term basis. You know, those are for short-term fixes. We can also use the benzodiazepines and some other central nervous stimulants, but again, there's some addictive qualities with that. But they are also driven to reduce the time that it takes to get to sleep and not necessarily maintaining sleep. It may decrease frequency of nights and early morning awakenings, and some of the ones that I want you to look at are basically in your book on page 230, and you will see they're broken out by insomnia, the medications used to treat them as far as the non-barbiturate hypnotics, the benzodiazepines, and the antidepressants. So you can look through those, and what you really want to focus on are those nursing considerations on the far left on page 230 and 231. The non-barbiturate hypnotics, there's also listed there. Caution used in those because with alcohol and drug abuse and pregnancy, they do have an addictive nature, so those are used very sparingly. Over-the-counter and complementary therapy should always be accomplished by appropriate assessment, diagnosis of sleep disorders. And if we're using diphenhydramine, be careful that is not used in the geriatric population, because it does have some drowsiness and the anticholinergic effects that are associated with diphenhydramine. And actually it can last up to 18 hours. So it can cause the elderly population to have some lasting effects from that. CBT, or cognitive behavioral therapy for insomnia, sometimes that is used as we need to look and address the issues or negative sleep patterns and beliefs that the patient has. It may be necessary for sleep disturbance if sleep disturbance continues. And it best treats chronic insomnia, especially when it's combined with some sort of sleep restriction, sleep hygiene, or other non-pharmacological interventions. Some nursing interventions that we do for people with sleep-wake disorders. Many people reporting sleep difficulty may not experience an actual disorder, but a thorough assessment is necessary. Sleepiness, it can be caused by numerous precipitating factors, medication side effects, neurological injuries, stress, issues going on in their life at that time. So we need to be able to assess what's causing those. And to do that, you can use the full assessment versus at the logarithm on page 223 or 233, excuse me, and it can take you through basically the steps that you're going to ask. Do you have problems with sleep? Yes or no? Do you wake up feeling tired or restored? Are you sleepy during the day? If no, you're done, because that means they don't have any problems. But if yes, then you want to consider one of these other next questions. So read through this logarithm and read the questions, kind of look, what type of questions are we asking? What are we looking for? There's also a sleep study scale that you can use. So make sure you look at that to help you guide the questions that you're going to look at. And basically, here's the logarithm that I was talking about. Again, it's on page 233 in your book, but I also have it in the slides for you. Diagnosing and planning. 2 NANA diagnosis: sleep deprivation, sleep pattern disturbed. But plan of care should always include appropriate sleep hygiene. And sleep hygiene is talked about on page 235 on table 12.4, and I also have it in your slides, and we'll discuss that in just a minute. Plans and goals. Again, you always want to involve the patient in this planning. Questions you can include is the patient capable of helping develop this care plan? What are the symptoms the patient states most distressing? What does the patient need or want to achieve? And make sure, remember, they're specific, realistic, and measurable goals. And make sure you address those 5 domains. Back on that very first slide, or that, not the very first slide, but the very first table that I showed you, that table 12.1, where it's talking about the domains of sleep disorders. You need to follow through and make sure your plans and goals address those too. Also, you want to make sure you revise after you evaluate the care plan, making sure it's addressing the recovery and the rehabilitation once they have crossed into that realm of recovery. Reevaluation when the patient's sleep improved. Behavioral therapy to reduce hypnotic medication. We don't want to leave them on those hypnotics or those benzodiazepines for a long period of time. Remember, because they do have those addictive qualities. Compliance with their CPAP. If it's a sleep apnea patient, you want to make sure that they're wearing their masks, using those as needed. Individual interventions may include education on your prescribed medicine, normal sleep requirements, consequences of insufficient sleep, how to access appropriate referrals, and sleep hygiene. And here's the sleep hygiene that I was talking about. Good little chart. It's on page 235 in your book. Some interventions that we can tell patients to try, as well as the rationales to help those. Implementation to promote sleep. That's what we want. We want to ensure uninterrupted sleep time. Often relaxation 90 minutes before bedtime. Start winding down, as the old saying goes. Encourage quiet sleep environment free from staff, chatter, quiet noises if you're on the floor, and provide that dark room to sleep in. Then, of course, evaluation. Evaluate if it works. If it didn't, back up and repunt. You want to assess for adherence of the treatment plan, the patient's knowledge, negative emotions, physical consequences, recommended treatments. Make sure that they are following those. Remember, sleep disorders are treatable. There are several options for treatment, and nurses play a key role in recognizing and initiating re-referrals. We're the one that the patients, when we go in and ask, well, how did you sleep last night? Well, I slept terrible. We're the ones that's going to get that. So we're the ones that we really need to focus on. So there is the audio and video for chapter 12.